Well, it gives me great pleasure to introduce our next speaker, who has a unique journey and a unique story. She is a person with narcolepsy, and she is a parent of a child who was very young at onset and diagnosis, and he also has narcolepsy. His name is Dylan. You might know Lanna Barrison on social media because she's got a feed that is called Wake Up Dylan, and she's been a writer and author, a blogger for some nearly 10 years. So Lanna, welcome. I'm going to introduce you formally. Lanna is a mom to 2 human children, 1 canine child and 1 canine angel. She is a lawyer by training, a legal marketer by profession, a narcolepsy advocate by necessity. Lanna's son Dylan was diagnosed with narcolepsy and cataplexy at the age of 3. He was Canada's youngest child with narcolepsy and later became Canada's youngest child taking Xyrem. Lanna has also been diagnosed with narcolepsy, giving her a unique perspective on Dylan's daily struggles. A sarcasm, enthusiasm, and self-pity pro, her blog Wake Up Dylan uses what she claims is humor to raise awareness for children with narcolepsy. Lanna, welcome. Lanna, do you want to unmute yourself and switch on your video?
Sorry, I thought I had done both things.
No, it's nice. Thank you for taking the time. I'm so excited to hear your unique journey. I've caught bits of it along the way. Of course, you and I have somewhat parallel lives, except I do not have narcolepsy, which is a significant difference. So huge respect and shout out to you. I don't know how you do it, but please share with our audience how you do.
Well, I'm sleepy a lot, but thank you very much for giving me the opportunity and asking me to speak. I think that certainly Dr. Narang is right, and the more that we can create awareness, the more that will help. So I'm very happy to be here and sort of share with you my somewhat unique story. I mean, I think when we talk about narcolepsy, they're all unique because it's such a unique disorder, but there are some really, really unique aspects about my story. And so I'll give you a quick overview of what I intend to talk about in the presentation. And the first is I'm going to introduce you to my sleepy family. The bulk of my presentation will center around my son Dylan, who was diagnosed when he was 3, but it is sort of a family group event at my house, so I'll share a little bit about that. And then I'm going to share what narcolepsy and cataplexy looks like in real life. So there's a lot of literature about it, less so about children with narcolepsy. And you know, in my opinion, and if you speak to my son, it's a really different disorder in kids than it is in adults. So speaking as an adult who has narcolepsy and as a parent of a child with narcolepsy, it's almost as if they're completely different disorders, and especially for really, really young children. And often the really challenging symptoms are not the textbook ones. They're not the ones that we're talking about all the time, or they're not in the leaflets. It's the really emotional and behavioral ones that are challenged. So I'm going to share with you 2 videos that I have that really just give you a snapshot of what it's like to parent a child with narcolepsy. And then, as I've mentioned, I really think there are very unique challenges that come with being a very young child with narcolepsy and parenting a very young child with narcolepsy, even if you yourself have narcolepsy. It's just a completely different world. So I've outlined sort of some of the challenges that are unique because you're 3 years old or you're 4 years old. So as promised, this is my family. Dylan, who is at the bottom there, he's the Dylan in Wake Up Dylan. He was diagnosed in 2014 at the age of 3 with narcolepsy. And as a result of his diagnosis, we learned that 2 other people in my family also have narcolepsy. And I'll get into that.
Sorry, your slides aren't showing. Sorry to interrupt you. Your slides aren't showing. And we're desperate to see your family.
How do I?
So screen share. We don't want to miss this. There you go.
Can you see it now?
Yes, perfect. Thank you.
Excellent. Sorry about that. I'll go back really quickly. There's the overview, just in case this is going to be shared later on. And then here's my family. So hopefully now everyone can see the Mr. Dillon, who sort of started our journey with narcolepsy. And it's very fair that I say that I'm the favorite wife, favorite mom, and favorite daughter, because I'm an only child, and I'm the only mom my kids have, and I'm the only wife that my husband has that I know of. So I am the favorite. It's not up for discussion. So as I mentioned, the bulk of the presentation will be about Dillon, because he did start it all. And then another fact that I have for you is that, and a lot of people might not know this, is that Dillon is actually the world's cutest child with narcolepsy and cataplexy. And as proof of that, there are 2 pictures of him. At one point, he was Canada's youngest child with narcolepsy. His symptoms started appearing when he was 2, but officially he was diagnosed at 3. And then shortly thereafter, well, maybe not short enough, when he was 4, he then became the youngest child in Canada on Xyrem. So, this is Dillon's diagnosis journey. It's fairly typical. The one thing that's a little bit different is really how quickly we got a diagnosis. Most parents, most patients with narcolepsy will tell you that it's a really long time. For me, it was 20 years. For Dillon, it was about 6 months, which is exceptionally fast. And really the only answer I have for that is that I'm a Jewish mother, and yeah, I just get things done. I basically wasn't taking no for an answer, but it really was remarkable how quickly we were able to get a diagnosis. And I think partially that's the Canadian medical system, healthcare system. And partially it's sort of just knowing or thinking what your child is struggling with. So as I mentioned, symptoms appeared when he was about 2. Pretty typical, right? So he was really sleepy. I thought it was adorable. I was taking pictures of him asleep in his car seat, asleep on the playground, asleep here, posting them to social media. Isn't it so cute? He loves to sleep like his mom and his Zadie. Then the most noticeable symptom was a protruding tongue. Had no idea at the time, obviously, that it was cataplexy. Thought maybe it's like a weird habit or tic that he's picked up. Thought maybe his tonsils were making it difficult to breathe. Weren't really sure, but it was something we noticed, although it wasn't something we were terribly concerned with. But very, very soon after, we're talking a couple of days, he became a completely, entirely different person. So my happy, always smiling, go lucky, fine with everything, jokester of a kid was irritable, frustrated, angry, aggressive. But I didn't know this kid. And I often will talk about how you have to mourn the loss of your pre-narcolepsy child and accept this new one into your life, because it's like you're adopting a new child, completely different. And that was sort of the red flag for me as a mom to say, something's not right. Don't know what's not right, but let's go to the doctor. And so I'm really, really glad to hear that things have changed since, because we did not have the experience that pediatricians knew about narcolepsy, or in fact, any doctors that specialize in pediatrics. And I don't for a second fault them, because why would they, right? It's not often that you see a 3-year-old with narcolepsy. So it makes total sense that they wouldn't be familiar with it. And like many parents on this journey, often the first sort of trial is to get your tonsils and adenoids taken out. And there's, good supporting evidence for why you would do it and how it might help. And so we were helpful. I remember I got my tonsils out at 5. It wasn't really a big deal. Let's try it. And I have to say that as minor a surgery as it is, it's sort of insignificant as it is, by far, without question, it was the most traumatic event for Dillon, myself, and my family in the 7 years that we've been dealing with narcolepsy. So there's really nothing that was worse than when he had to take his tonsils and adenoids out. And I mean, I think a large part of that is we were dealing with a 3-year-old who had undiagnosed narcolepsy and we didn't know. And so you have to remember he was at his most aggressive, most frustrated, most irritable. And I'll never forget when the nurses were coming to take the kids, many of the nurses, hi, my name is Sandy, and I'm going to be your nurse today. And another nurse will come, hi, I'm Betty, and we're going to have fun today. And of course, the nurse was like, come with me. And immediately I said to my husband, this is not going to end well. And I sort of said to the nurse, can you maybe just introduce her? Because she scooped him up, and immediately he started just beating on her. Literally, I mean, his little 3-year-old body, that's what he looked like, the picture at the bottom, but he just started pounding on her. And we saw the doctor have to come in and sort of rescue her. That whole experience, I know it's sort of one of the first things you try. It was really hard. We weren't allowed to leave the hospital until he would have something to drink. They would give him a popsicle, he'd whip it at the other patients. He refused to swallow because it hurt, so he would just lie there with drool. It was hard. But at the same time, we were hopeful because we had heard great promising things that, in 6 to 8 weeks, he'll be a different kid. And I really, really, really wanted to believe that. But something inside wasn't hopeful. And sure enough, we came to the 8-week mark, we came to the 10-week mark, we came to the 12-week mark. Nothing much has changed. And a perfect example of sort of the pediatric doctors not really knowing is we would go back and I'd say, okay, so we did this. Still the same, what's next? And we got answers like, well, it could still be the anesthesia from the operation. The anesthesia from the operation that was 16 weeks ago, yeah, it could happen. Okay, so at that point, I decided I either need to get a degree in medicine and figure out what's going on, or I just need to immerse myself in Google, which is what I did. And so I started doing a lot of searches, as you can imagine. And for some reason, I thought maybe some of his protruding tongue or his mannerisms, for whatever reason, my first thought was epilepsy, which is not uncommon. And long story short, I ended up initially searching for epilepsy, finding a YouTube video of a girl who had narcolepsy, and she actually was a twin. And the video was intended to capture a cataplectic attack that she was having. But that was almost irrelevant to me because at that point, Dylan wasn't having those full body cataplexy attacks. What I immediately picked up on was this unique and so specific, and I'm sure if you ask any parent with a child with narcolepsy, there's this certain specific frustration and irritability that comes from a kid who has narcolepsy. It's very easy to hear and pinpoint, and it's usually over the most simple, mundane things. I think in the video, it was like over a can of pop, right? And immediately, as you sort of saw the escalation of this fight with her sister, you heard the mom who was filming say, okay, just whatever, just leave it, let it go. And I knew just from that sort of reaction, Dylan has narcolepsy. And so then at that point, it was, how do I prove it? So he went through all of the regular tests that you would expect. He did the nighttime sleep study. There was some concern that he was just too young to do a daytime sleep study. How do you tell a 3-year-old to sleep every 2 hours? Well, if they have really severe narcolepsy, it's not an issue. So he went through all of that, and everything pointed to narcolepsy, but he was still 3, and that is still something that a lot of doctors struggled with. He's still 3. To rule out anything else, of course, he did the MRI, which I don't know if I'm the only one that experienced this, if this is common, but I remember sitting there waiting for the MRI to happen. And honestly, I remember texting my best friend and saying, I don't know what outcome I'm hoping for here. Do I want a tumor that potentially could be operable and then he would be my old Dylan again? Or do I want narcolepsy, which I know isn't terminal, but it's chronic and it's lifelong, and this is a lot to deal with for the past 6 months. I can't even imagine having to deal with it for the rest of my life. I honestly was sitting there torn, and I think if I'm truly honest, was hoping for a tumor, which I think, A, it's embarrassing for me to admit that, but I think B, is it really goes to the struggle and the challenge of narcolepsy, which when you sort of just boil it down to sleep, it's so much more than that. The MRI, much to my chagrin, was normal. There was no tumor, which in retrospect is probably a good thing. He did the genetic testing. I mean, everything literally pointed to, yes, hello, you have narcolepsy. This is textbook. We did have to also go see a pediatric psychiatrist and a neurologist. And it's interesting because they were pediatric, they had very little experience with narcolepsy, as you would expect. right? Because they're not seeing this all the time. So we went to see the pediatric psychiatrist, and there was also, we strongly believed that we were being sent to see the psychiatrist because there was a sort of underlying disbelief that really this could all come from a lack of sleep, and maybe he's just a bad kid. That was a constant feeling we had. It was nice when we spoke with the pediatric psychiatrist that he quickly quelled any of those concerns. I mean, he was very clear in saying, this is an emotional regulation issue that stems from his exhaustion and just his brain not having the ability to do all of these things. What was really interesting is that we were also told we were meeting with the pediatric psychiatrist because we needed his guidance on whether we can give a 3-year-old Prozac, Effexor, any of those antidepressants. We don't really know. And as it turned out, he didn't really know either. And again, why would he? He's a pediatric psychiatrist. And he very candidly and honestly said to us, I'm going to go Google it because I'm a pediatric psychiatrist. I don't typically prescribe antidepressants to 3-year-olds. So that was an interesting sort of situation that we had that really sort of tainted our dealings with pediatric doctors, unless they were pediatric sleep doctors, and then we're familiar with narcolepsy. We had a very similar situation when we went and spoke with the pediatric neurologist. He was able to rule out there was nothing else wrong, but he'd never experienced or dealt with a child with narcolepsy. And again, why would he? He's a pediatric neurologist. So that's sort of the path that we went on to finally get the diagnosis. And it really was sort of like very clearly all the tests pointed to yes, this is narcolepsy, but then the doctors were very insistent on ruling everything out, which I understand. As I mentioned when I first introduced you to my family, 3 of us now have narcolepsy. Well, we all had narcolepsy, but we didn't know it. And Dylan was the trigger. So he was diagnosed in 2014, and throughout his diagnosis journey, doctors would say to me, like, is there a history of sleep disorders? And to every single doctor, I would say, I really like to sleep. My dad really likes to sleep. Like, sure, if you give me a pillow, I'm going to sleep. But still, I'm here sure as anything that my son has narcolepsy, and sure as anything that I don't. Dylan's doctor then turned to me and he said, you need to have a sleep study. I think you might have narcolepsy. And I said, no. Like, I'm not at all like Dylan. I sleep through the night. I don't wake up once. I close my eyes. You won't hear from me again until someone's shaking me to wake me up. Dylan's up all the time. I don't have cataplexy. There's no way that I can have narcolepsy. I have narcolepsy. I don't have cataplexy. And knowing that I have narcolepsy totally makes so much sense with respect to the past 20 years of my life. I can tell you the day I started displaying narcolepsy symptoms, I was 15 years old. I was on a cruise to Greece with my parents, and all of a sudden, I could not stop sleeping. But we had really good answers for it. I was on a cruise ship, so I was being lulled to sleep. I was 15. At the height of puberty, of course I'm going to want to sleep some more. And my dad sleeps all the time. So I'm just, turning into my father. Now that I look at it through the lens of knowing that I have narcolepsy, it should have been really clear that I had narcolepsy. I, in university, would not take a course if it started before 2:30 in the afternoon. When I started working at a law firm, would every day take a nap in the library. These are things that probably aren't normal, but never sort of clicked to me. I think it also goes to my point of narcolepsy in children and narcolepsy in adults are very different things. You could not ignore what was happening with Dylan. You could easily dismiss what was happening with me. You shouldn't, but you could. So I was diagnosed actually after Dylan in 2015. My dad, he was tested very shortly after myself, but it was first discovered that he actually had extremely severe sleep apnea. I think within an 8-hour sleep study for 3 hours, he wasn't breathing. So the doctors sort of credit Dylan for saving my dad's life because his apnea was that bad. And he went through a number of years of, finding the right CPAP machine. It was terrible for him. He couldn't really find one. He finally found one that's sort of like a mouth guard. And that started working, and it really, really made a difference. And once he was retested with this new appliance that he had, out came the narcolepsy diagnosis as well. So it sort of appears, I don't know if it's common or not, that the sleep apnea was masking the narcolepsy that he had. And so The three of us all have narcolepsy. We know that Dylan has the alleles that are highly associated with narcolepsy. We're assuming that we probably are carrying that as well, though we don't know and we haven't been tested. We also all share sort of this common autoimmune other disorders, right? So for example, both Dylan and my dad have anaphylactic allergies, Dylan to peanuts and tree nuts, my dad to shellfish. I have very bad seasonal allergies. And actually when I do an allergy test, it says that I am allergic to peanuts, although so far I can eat them. But I do have something called iritis, which is a really, really, really painful eye inflammation. And it's often linked to many other autoimmune disorders like rheumatoid arthritis, lupus. And immediately when I read that, I said, well, I have narcolepsy. But, you know, again, any doctor who doesn't really know about narcolepsy wasn't sure. And so my ophthalmologist and my optometrist, maybe we don't really know, we'll run some tests. And my sleep doctor said, yeah, I mean, it totally makes sense. So, you know, there are certainly autoimmune issues that we all share. So I like to share what Dylan's cocktails of medication is, because often when I describe to educators or instructors that Dylan has narcolepsy and it's a sleep disorder, for whatever reason, and Dr. Narang alluded to this, it's kind of dismissed. Oh, sleep. But it is so vital, and it has so many negative effects when it's ignored. And it isn't often until I show the teachers or whoever I'm talking to the laundry list of medications, which I've often been told is some of the most complex and frightening list that principals who've been working for 20 years with special needs kids have seen, that it truly sort of solidifies how serious and debilitating it is when you see that a 4-year-old is taking the date rape drug, muscle relaxants, stimulants, all at once. It sort of puts things into perspective, although I hate to do it. And it often becomes an excuse for, well, it could be a symptom of the medication. It really does put it into perspective. Obviously, Dylan has tried a whole host of different medications, which anyone with narcolepsy or parent of someone will tell you, it's a lot of trial and error, especially for very young kids. And I'll speak to that in a few minutes in some of my other slides. But I think what's interesting here is anyone familiar with narcolepsy will immediately recognize some very common medications here, you know, very often prescribed. And then I think that there will be a lot of surprise medications, ones that parents maybe have never heard of, ones that doctors likely have heard of, but just never thought for narcolepsy. And so I'm going to put it out there and just say, you know, if you want to put it in the Q&A, I'm curious to know what you think is the most important drug that we currently give to Dylan. So out of all of these and sort of knowing what they do, I'm curious to see, you know, if someone's put a gun to my head and said, Dylan can only take one medication, what would it be? It's a very clear answer. There's one medication that stands above all else, and I would never give it up for anything. And for whatever reason, it's not often used in the treatment of narcolepsy. And I think that's because there's no guidebook in the treatment of narcolepsy, especially for young kids. So if you kind of want to guess what it is, you can put it in the Q&A and then I can answer it at the end. I'll leave you guys all in a bit of suspense. So as I mentioned, narcolepsy and cataplexy, it's so much more than what you read in the pamphlets and in the booklets. And I think that the reason that if you read, you know, Claire's blog or my blog or anyone's blog, that it is so impactful and powerful is because you're getting what you don't get in the medical literature. And that's the feelings and emotions and stress and behavioral issues, which really are just a manifestation of exhaustion. That's really what it is. And that's what's hard. We can get through the sleepiness. We can get through the hallucinations. We can even get through the cataplexy, which is tremendously difficult, but we can get the behavior, and the result of this exhaustion is really, really tough. And so I often say that sleepiness is to narcolepsy what incontinence is to old age. It's a classic common symptom, but it's not the one that kills you. So I put together, as I mentioned earlier on, just a video to give you a snapshot of what was going on in my house when Dylan was about, I'd say, between 3 and 5. So very much on the younger end. He's almost 10, he'll be 10 in a few weeks. And this was at the beginning stages. Some of it is before we found any medications that work. Some of it where he was fully medicated, maybe too much so. This is what narcolepsy is. So I'm just gonna play it. And Claire, just let me know if maybe there's technical issues with this as well.
We don't have to get high, even on a Saturday night, to get your fingers out of that pie and do it with a wink and a smile. It's way past your bedtime and you should be shutting your eyes, but you're out painting the tile and your mother doesn't even know why. We don't have to get high, even on a Saturday night, so come on, give me a try. We'll strap ourselves in and go flying over the white cliffs of Dover. It's true, I'm sober and I'm blue, flying over the white.
I want it. Why, Mommy? Why? Why?
We don't have to get high.
Help me.
I can't, Dylan.
Can you help me?
I just told you that I can't.
Help me.
We don't have to get high, even on a Saturday night, 'cause this love's turpentine. We'll strap ourselves in and go flying over the white cliffs of Dover. It's true, I'm sober and I'm blue, flying over the white cliffs of Dover into October. Looks like you.
Hey! Mommy! Mommy! Mommy!
I love you, Dylan.
I love you too.
I love you so much.
I love you so much.
I love you more.
I love you.
I love you the most.
I
I
love you.
love you. I 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 love you.
And do it with a wink and a smile.
So that's narcolepsy in real life. Not really what you read about. And I've sort of outlined hopefully what you saw in the video. And these are really the killer symptoms, right? It's that extreme irritability for which there's no predictability. So it's not like, let's say, kids with ADHD who we know there's certain triggers we want to avoid. It's really completely unpredictable. We never know what's going to trigger it. And there's really no way to get him out of that irritability. Once he's in it, he starts perseverating. There's no logic and reasoning. It's just, we sort of have to wait it out. There's frustration, anger, and remorse. It's this sort of circular cycle where Dylan gets very, very frustrated, which makes him really, really angry. Something bad happens. He's maybe hurting someone, saying something he shouldn't, damaging some item in the home, and immediately, instantly, he's remorseful because he doesn't want to have done that. He knows he shouldn't have done that. And the remorsefulness is just tears and guilt. He can't settle. Often he'll say, I got to write a letter, I'm sorry. Like he is truly remorseful. We've never been in a situation where like, Dylan, say you're sorry. Oh, I'm sorry. That never happens. It's just extreme. More often than not, if he's hurt a kid, let's say, it's the kid who was hurt that's coming to Dylan and saying, are you okay? It's okay. Because he's so distraught. And it's very clear that he doesn't want to do what he's just done, but he couldn't control it. And as a parent, it's not an excuse. Like, you can't tell me you can't control it. You have to learn how. But it is this cycle that it's very hard to break. And the older he gets, the more attuned he is to this, because he wants to be good. He doesn't want to be doing this stuff, but there's sort of just moments where it gets away from him. The other piece is the avoidance and the social anxiety. So the easiest, simplest thing for him to do is nothing. It's to stay at home, avoid having to deal with other people, having to risk having a cataplexy attack. And I think that it's this issue in particular that really stems from the cataplexy and the embarrassment of it is what oftentimes has educators and therapists and health professionals immediately jump to the conclusion that Dylan has, maybe he's on the spectrum, maybe he's got ODD or, ADHD. It's because his avoidance is misinterpreted as a lack of desire to be with other people. He wants to be with other people. He wants to be social, but it just never ends well. And so he avoids it. And that's very different than just not having a desire to do it. He's also got very much, because of this lack of exhaustion, very typical ADHD-like behavior, which seems like the two can't be related. How can you be so sleepy and suffering from a lack of sleep and then be so hyper? Well, as we know, even for ADHD, it's because of the lack of sleep. The unfortunate part is we can't really fix that. We're trying, but we won't really be able to fix it. And using medications like Ritalin, for example, which are often used for ADHD, have to do double duty for Dylan. So they have to keep him awake and keep him focused. And so I think it's hard. I think it's hard to expect that of a medication. So that's a huge challenge as well. I think this flows very nicely from the presentation we just saw, which is the focus on the need for therapies. And to echo Dr. Narang, there really aren't specialists that can help with this. And so I just did a lot of what's the closest here, because the reality is there's no guidebook for narcolepsy, whether you're in school, whether you're in therapy. And so you sort of have to source your own guidebook, and you take the parts of ADHD that are similar to narcolepsy, and you take the parts of OCD that might be similar to narcolepsy, and you sort of piece together the professionals that would work for you. And that's kind of what I did. So there's a lot of therapy that goes along with narcolepsy. And I think that's also something that isn't as often seen or talked about in children. So the support and the group therapies and the focus on mental health just in general it's definitely gaining more awareness for the adolescents and for adults, but for kids, it's sort of forgotten sometimes. And I think it's just equally as important. I think that also there might be other underlying issues. And when you're so focused on the narcolepsy, you don't always notice the other things. So for example, Dylan has vision therapy, which is not really related to his narcolepsy in any way, but it's because of his narcolepsy that we completely missed the fact that he has no 3D vision. See, he couldn't see anything in 3D. We would go to a 3D movie and he would take off his glasses, and that was more comfortable for him than wearing the glasses. He would often, we all noticed, he would close one of his eyes. We now know that's because he couldn't see in 3D, but this also goes to something that's unique to very young children and something the presentation previous to mine spoke about, and that's the kids make up their own strategies because they have to, because no one can provide them for them. And so they just learn that if something's bothering them, figure out a way to fix it, which might be one of the advantages to having narcolepsy really young, because almost since the day that Dylan can remember, he's had to create strategies. And so his OT, for example, noticed that if he's going to go down with a full body cataplexy attack, the first thing he does instinctively is grab his head. No one taught him that, but he just understood that he needed to figure out a way because he didn't want to hurt his head. And he's young, right? He was 3 or 4 at the time, but he just figured it out. with the vision therapy, he somehow figured out that if you close one eye, you don't have to worry about your eyes fighting together to see in 3D, you just see one. So it's very easy to miss. And I think that definitely children with narcolepsy would benefit greatly from different types of therapy. I think you can't complain about the behavioral aspect of narcolepsy, which we all do because it's one of the most challenging. And if we're medicating for it, we should also be engaged in therapy for it because it helps. It really does. I mean, there's just something to be said for maturity and growing up, but it also, any strategy we can give him is better than nothing. So cataplexy is discussed in the literature, and it is definitely one of the common symptoms, but I think that it's sort of more viewed as careful. We want to make sure that, you know, he or she doesn't fall and hurt themselves, which is valid, definitely, but that's not my concern. And that's not Dylan's concern, because the truth is he's never really been very badly hurt in a cataplexy attack. What we're concerned about is what it prevents him from doing. It prevents him from playing with his friends. He just can't. He can't keep up because the minute he has fun, he's down. Therapy, there's so much therapy that involves activity and sports, and the more fun it is, the less he can do. You know, there's a lot of therapy that they can do with hockey sticks and stuff, but he always has to use one hand to sort of hold himself up when he thinks he's going to have a cataplexy attack, so that limits him to one hand, right? So try playing hockey with one hand. So I think it's those elements of what is cataplexy preventing you from doing that maybe a lot of people aren't attuned to, even adults, right? Because I think it's less of a concern as an adult. Well, I can't participate in this group activity. And it's really, really real for kids. And I think well, if you ask Dylan, it's the worst symptom by far. And so just like the other video, I have a video that's dedicated specifically to cataplexy and how it impacts his play and just him being a kid.
Welcome to my breakdown. I hope I didn't scare you. That's just the way we are when we come down.
Gray Squadron Pilot.
Gray Squadron Pilot.
A-Wing Pilot.
A-Wing Pilot.
Luke Skywalker.
Luke Skywalker.
Princess Leia.
Princess Leia.
Rebel Commando.
Yeah. Welcome to my breakdown. Whoa. Welcome to my nightmare. Yeah.
Now, wear your shoes untied. What do you need to worry about? Right.
Here comes the funny part. Here comes the funny part. Funny part. It's my cataplexy. My cataplexy is not bad. Oh!
Sophia, if you hit with one side, it will go more to that side.
Sophia, don't make me fall.
It's not Sylvia's fault.
Baseline has better. No. I love you.
I think you're gonna like it. I think you're gonna feel you belong. We're sweating, laugh and scream here, 'cause life is just a dream. You know inside you feel right at home. Yeah. Welcome to my nightmare. Welcome to my brief.
Just reading something that it has farts on it.
Oh, that's my favorite book.
Oh,
You okay, Dylan?
That noise is so stupid.
I also made that video in part because I was at a conference, and there were parents who were asking questions specifically about cataplexy, and a lot of the questions were, is this cataplexy? Could this be cataplexy? And I think sort of explaining it as a loss of muscle tone is very vague. And as you know, a parent of someone with narcolepsy, and I think a lot of the parents who are watching can probably very easily say, yeah, that looks like narcolepsy, even if it's not, you know, sort of textbook cataplexy. We know what it is, but it's very hard sort of for teachers or educators or even parents who aren't really sure what their kids might have to identify it. And so hopefully this will sort of share what it can look like. And this sort of wraps up a lot of what I was saying, which is that there are a lot of really unique challenges that are faced, particularly by very young children with narcolepsy, that as an adult with narcolepsy who had it as an adolescent, I can tell you make it a very entirely different disorder. So one of the most obvious, of course, is the medication limitations. A 3-year-old can't swallow pills. You know, Dylan now is a professional pill swallower, and he impresses many adults with the amount of pills that he can swallow in one go. But at 3, it wasn't a possibility. So anything that we wanted to prescribe to him had to be crushed. Not all medications can be crushed. Anything that's extended release, long acting, that can't be crushed. So there's right away a whole bunch of medications that are off the table for us. Then there's the element of a lot of them aren't approved for kids his age. That's an issue as well too. Then there's always the concern of, well, he's starting medication at 3. He'll build up a tolerance. What's that going to look? So for the vast majority of his life, he's going to be medicated. What does that look like? Is he, you know, even if we cycle through all the different stimulants and all of the different, at what point does he just run out because he started at such a young age? And then a lot of these medications, you know, negatively impact other aspects of growth. Ritalin, for example. I mean, we're fortunate, knock on wood, that he's pretty tall and has a very healthy appetite, which has a lot to do with some of the other medications he's on. So we're not terribly concerned, but for a lot of parents, putting their kids on a stimulant who are already small and aren't eating isn't an ideal solution. There's, of course, the immature communication skills. So if he's having side effects from a drug, he may not even know that it's a side effect from it, but can't even describe it to us. So I started taking it, whatever medication he was prescribed, I was going to take it. And I can tell you, bifenthrin, not a fit for him. But it took us about a year to realize that it was the bifenthrin making him angry and irritable and frustrated. We just assumed it was the narcolepsy. And he was fine on Ritalin. And every doctor told us it's the same. Ritalin, bifenthrin, it's the same, but one's long acting. It's not the same. And I think that maybe in an adult, it might be because the slight, because I can tell you I felt differently, but I could also control it and you probably would never know it. But in a 3-year-old, they can't control it. And so those slight changes are magnified. There's obviously the self-regulation. That's, I mean, it's hard for adolescents. It's hard for adults. I can speak for myself. Sometimes I just want to yell at everyone and say, please stop talking to me and let me rest. But for a 3-year-old, there's no filter. There's no what's socially acceptable. They don't care. Right now, I want what I want and I'm going to get it. One of the most significant issues that we struggle with is that Dylan got narcolepsy so young. He was 3. And so most of what he had to learn in life, he had not learned. And this is specifically challenging for a lot of those foundational skills. So we were lucky that he was, at the time advanced. And so he knew all his letters and sounds, he knew all his numbers, but that's it. He didn't know how to read, he couldn't do any kind of math. And that's hard enough as it is. But when you are also dealing with a kid who basically lost 2 years of his life to sleep, so is now behind and now has to learn these very foundational basic skills on which the rest of your academic career and social life will depend on, it's really challenging because you have so limited hours and just the motivation and focus aren't there. I touched on the developmental years too. I mean, so much of your developmental growth is learned through play, particularly the really young years of 3 to 5 when Dylan was asleep. Most kids are learning to share, to cooperate, what's socially acceptable, what's not, what's expected behavior, what's not expected behavior, how to react, how to take turns, all this simple stuff he missed out on. He didn't learn it. And it's not like, oh, now he's medicated and he just naturally has it. No, he has to learn it. And so just by nature of learning it late, he's now behind in everything. This is one that's fairly obvious, and I'm sure affects adolescents, maybe even more so than children, really young children and adults. But I mean, as a parent, it's a clear indicator to me that Dylan's having fun. So he can't lie to me about not having fun or having fun. I know that at his birthday party, with his tongue out and his, collapses, he's having a good time. That warms my heart because I'd rather know he's having a good time. He hates it. And the double-edged sword of therapy is that they become more self-aware because you're teaching them about other people's feelings and perceptions and expectations. And with that comes also understanding that people are judging you and looking at you and that you aren't the same. You can't keep up. And Dylan's had a very, very good school experience in that nobody has singled him out for being different. He's not being bullied. I find kids these days are so welcoming and open. But he still can't do things. He still can't run and play football with them. He still can't play baseball with them. And that's hard. Probably one of the hardest challenging aspects of narcolepsy in very young children for both parents and children is this bad kid label. I mentioned it early on, we were referred to psychiatrists, but it's a constant, right? It's just, for whatever reason, it's really hard for a lot of educators to believe that all of this could stem from sleep. But sleep? Really? Are you sure it's not ASD? Are you sure it's not ODD? And that is always the first jump. And I'll never forget Dylan's doctor saying to me very early on, Dylan has narcolepsy. It's not autism. It's not ODD. It's not ADHD. He has narcolepsy. But you will encounter people who will argue with you. And it's been absolutely true. And I stick firm in, this is the narcolepsy, guys, this is the narcolepsy. And anytime he is tested and you really sort of put in place the tests and checks, he doesn't pass. It's narcolepsy. But it's very hard for teachers to accept that for some reason. And to the point where he, I have to tell this story. When he was 6 in grade 1, he got a D+ in music. And I thought, that's weird. Like, what is a 6-year-old in grade 1 doing so badly that deserves a D? Like, is he singing backwards? Is he like picking his nose? Like, what could you do to warrant giving a 6-year-old a D+ in music? And especially when the year before, music class was used as a reward for him. So if he had a really good day doing literacy, then he would get to participate in music because he loved it so much. Long story short, he got a D+ because the teacher thought that he was having a tantrum in class. It was a cataplexy attack. And she would kick him out. So every music class, he's so excited. He's so excited that it's favorite class music. He'd have a cataplexy attack and he'd be kicked out of class. And because he couldn't participate, she gave him a D+. We're fortunate that it's sort of an isolated incident, but I think it sort of, and you have to believe me when I say I provided tons of literature about narcolepsy and cataplexy. I showed her videos of it, so she should have been aware. But there's this sort of perception that this can't be sleep. This is too much for sleep, but it is. Yeah, the learned helplessness is interesting. So there's just a natural tendency, especially when kids are so young, and especially when they're on such strong medications, to just do everything for them. And you feel your heart goes out for them, right? Like they're dealing with, so I'm going to do this, I'm going to do that. But as they grow up, they don't learn to be independent. They don't learn to do things on their own. They learn to just sit back and expect you to do everything for you. And why would they expect anything different? That's what we've been doing. Dylan was in grade 3, expecting his teachers to dress him to go outside and play. And I said, please stop, he can do it himself. And so then he convinced somehow his classmates to do it. One of the double-edged swords of having it when you're very young is that you do come up with these strategies, but you also learn to use narcolepsy in a manipulative fashion. So he learned very quickly that if he's tired, he can avoid math class. So guess who was always needing a nap during math class? He told his principal that because of narcolepsy, he can't go upstairs, so he needs to take the elevator. I don't know why she believed him. There was nothing in the information I provided that said he can't do stairs, but there's a tendency, people don't really understand narcolepsy. And so for fear of making him, okay, so Dylan's taking the elevator all the time. And then there's it's difficult to motivate someone when the easiest, simplest thing to do is nothing, right? And to expect a very young kid to be motivated by future rewards is really asking for them to have too high an EQ, I think, at a very early age. It's definitely something you can do as they get older, and we can even do with Dylan now as a 9-year-old, but as a 4-year-old, forget it. There's also very unique parenting challenges when you're dealing with very young kids. And one of the hardest one is discipline. By nature, I'm a very strict disciplinarian. If you speak to my older daughter, Riley, like rules are rules. If they're broken, there are consequences, the end. There are no exceptions, there are no buts. But there's narcolepsy. And early on, before we realized that he had narcolepsy and cataplexy, he was having what I thought were tantrums, where he would fall to the ground and not be able to get up. And I would get increasingly more agitated and angry that I'm asking him to get up and he's not. And I can't tell you how many days I sent him to his room to stay there until he stops having a tantrum. So then I learned, in fact, I was punishing him for having a cataplexy attack. So I have this constant guilt of that, coupled with you got to discipline them, right? Like no one in life will care that they have narcolepsy. Rules are rules. It's really hard. It's a very fine line of what's their fault and what's not. What do you punish and what do you not? There's obviously the financial aspect that I can't imagine there's a parent on the planet with a child with narcolepsy who isn't worried about this. But when they start at 3, I mean, my symptoms first started when I was 15. I had a pretty good idea of what I wanted to do in life. My parents were pretty confident they wouldn't have to support me for the rest. I have no idea with Dylan. I don't know. I'm really hopeful he'll learn his multiplication tables. He may not. And so what does that mean for his future? There's also this sort of aspect of what if there's a new treatment or a new medication and it's super expensive, as it often is. We want to make sure that we can afford it. I never want to say to Dylan, you're denied the best because of money. And so you're always sort of, do I get this purse or is that 2 more therapy sessions, right? There's this constant, it's never enough. You become the expert on everything, including medicine and education. I can't tell you how many times a doctor has looked at me and said, do you want to give him this medication? And I said, you're the one who went to med school. You tell me. I don't know. And the doctor said, I don't know. We've never given this to a child so young. We don't know what the long-term effects are. You have to decide. For education, what kind of class are we going to put him in? Are we going to put him in a class with learning disabilities? Are we going to put him in a class with ASD? Are we going to put him in a class with mild intellectual difficulties? Well, do you have a narcolepsy class? They don't. So you have to figure it out. Every decision that is typically made by professionals who are qualified to make them, you're now suddenly making them. Good luck finding a babysitter for a kid with narcolepsy. We had, before Dylan's narcolepsy, live-in nannies that would stay with us for the full length of their contracts. You know, we would hire one. She'd be with us for 3.5 years. She was like family. When Dylan had narcolepsy, we could not find a live-in nanny. I couldn't get past the first hour in the interview. I mean, it was just shocking how unwilling anybody was to work with Dylan. And I get it, he's challenging. Why not work with a different family? Local teenage babysitters are too young, not qualified. They cannot handle Dylan. Grandparents are amazing, but they're older, they're aging. There's just so much they can handle. I can't, ask them to take care of a hyperactive kid all the time. And who's going to babysit him overnight and give him Xyrem twice a day, right? At least if you're a teenager, you're maybe at the point where you can give yourself the doses. You don't need someone next to you. Young kids, they don't have that. So it's got to be me or my husband. And as you can imagine, this has mental health side effects, right? We don't ever get a break. Going on a vacation is nearly impossible. When do we ever sort of release that stress? And then there's sort of the parenting, which, you know, it's hard because you have two very different kids with two very different needs. And so they have to have different rules. And so one kid's looking at the other one saying, this is unfair. The other kid's looking at the other one and saying, why do I always have to sacrifice? And it's hard to find that happy medium. There's also just, you know, the divide and conquer, which I think if you speak to most parents or families, it's what you have to do. One kid goes here with one parent, one kid goes here with another parent. I seem to be the lucky one that gets my daughter a lot of the times, but the point is my husband and I are often separated because it's hard for the four of us to enjoy something together. And we want to preserve, you know, fun for my daughter and things like that. So we're separated, right? So my partner in crime, my chosen partner in crime, I can't fight crime with. We're separated. And then the other big issue, and this is something that I mentioned before, is that narcolepsy becomes your singular focus because it's so big and it's so all-consuming that other things, developmental issues, health concerns, they go unnoticed. Like I said, the 3D blindness, never would have noticed it if had the OT not picked it up for me. Developmental issues, I didn't know that you were supposed to be able to write this at that age. Didn't notice it because I was so hyper-focused on the narcolepsy, which almost makes you feel like you're a negligent parent, when really it's the opposite, you're too hyper-focused. And so in a nutshell, I think if I had to boil it down as a person who has narcolepsy and as a person who has a child with narcolepsy, without question, it's harder for the kids, especially the really young ones. I'll put it this way. There's a lot of talk right now about whether we're going to get my daughter vaccinated for COVID. She's 13. Of course, the concern is, what if it triggers narcolepsy? There's no science, but it's just obviously it's a concern. And I sort of said, you know, I got it when I was 15. She'll be fine. Like I'm not worried about her getting it as a 15-year-old. She can manage it, right? It's not great, but it'll be for the 3-year-old. It's not manageable. Like there's, you know, I'll take COVID, I'll take the flu, I'll take almost anything over narcolepsy. And I think that really speaks to how different these disorders are in adults versus children. And that's that. So thank you very much for allowing me to share my story.
Thank you, Lanna. We do have questions. I'm going to ask you to type them perhaps in a few moments. For those of you that need a break, please do take that. We're going to have our next speaker in 5 minutes. But Lanna, thank you. I want to ask you, are the videos of Dylan that you presented on YouTube?
They are, yeah. So, and there's a lot of them too. So there's ones that, for example, I put together a cartoon one for his class and for teachers. They're all sort of linked together under Wake Up Dylan. Okay.
I think there's such a huge educational resource. I mean, my mind went to, why aren't these used in medical school, you know?
Yes.
Even to do this presentation, which is incredibly thorough and 3-dimensional. And there were so many things that popped out that are just overlooked. You know, you even mentioned things like reduced growth, and, you know, there are so many elements to the condition with such a young child. Where can people find your blog posts?
So it's kind of sporadic because, well, I do have narcolepsy, but it's wakeupdylan.com. And I really try to sort of position it in a humorous way, well, at least for me, because that's my way of coping, right? It's horrible and tragic, so let's make it funny, because at the end of the day, I want to laugh. And so when I do blog about it, it's on Wake Up Dylan. I used to blog much more regularly. It was quite therapeutic. And now I sort of try and pick and choose the topics to point out those things that people really might not notice otherwise. Okay.
Well, you're doing better than me, because you did refer to my blog earlier, but it's actually completely inactive. But I do have a book on Amazon called Waking Matilda, if you're interested in reading a parallel story, but different gender. And of course, as I said, I don't have narcolepsy. One of the things that struck me, Lanna, was how you as an expert in Dylan didn't recognize some elements of narcolepsy in yourself or your father. Why do you think that was? because you are we are the experts. I'm actually looking at a potential sleepy diagnosis with a member of my family and may have missed it. So why did you miss it in yourself?
I think it goes back to my whole thesis of it's so much more challenging for really young kids. You can't help but notice it. You can't excuse this. There's no explanation. You can't blame it on hormones. You can't blame it on going to bed late. I could easily dismiss it for myself. My mom, when I was 16 or 17, coined the phrase narco-sleepy for me because, of course, I didn't have narcolepsy, but I could fall asleep anytime, any place, anywhere. Not realizing that, yeah, this is narcolepsy. And because my dad too was very sleepy, we just assumed we were people who like to sleep, right? It wasn't until I was going through the testing and I said to my friend, I'm so excited, every 2 hours I get to sleep. And she said, wait a minute, you're gonna be able to fall asleep every 2 hours? And I said, wait a minute, you can't? Like I didn't know, right? And so I think the biggest thing too is I slept through the night, or so I thought. And the literature really doesn't speak to that. It talks about the multiple wakings, which is very much apparent with kids. But adolescents, if they wake up in the middle of the night, we're not often going to our parents about it, right? So it can either be missed or dismissed.
Yeah, incredible. You really do have an incredible journey. Thank you so much for sharing it with us. I have a million questions. I think I'll have to call you separately. If you don't mind answering some of them in the Q&A, and you can just type them in.
Sure.
Because there are also, people did make suggestions earlier, when you sort of said what medication.
Yeah.
Do you want to just give us the answer?
Yeah, so the answer is risperidone. That's like the magic. I won't trade it for anything. I'll give you my Xyrem. It's risperidone. And that was the first medication where I saw glimpses of the old Dylan come back.
Can you say that one again?
Risperidone.
Okay.
I believe it's categorized as an antipsychotic medication. It's an anti-narcolepsy behavior medication in my house. It softens the edge, right? It sort of allows them to break through that illogical reasoning and brings back their personality.
That's incredible. Thank you.
My pleasure.
It was extremely moving and informative, Lanna. Thank you. And do say hello to a wonderful family for us.
I will.